of having the outcome. Okay, so I'm interested in people only who took the drug. So I have two groups. A group took drug A and a group took drug B. Okay, now if you look at here, in drug A, I gave it to 100 people. Am I right? But 5 patients did not take any medications. What does it mean? Out of the 100, how many are left? 95. Very good. So, and those 95, 2 patients took drug B, so they switched to the other group. So how many are left? 93. Now, in drug B, you have 3 patients who took drug A. So 93 plus 3 is how many? 96. This is why in the efficacy I used 96 here, because 96 people eventually took the drug. Okay? The same thing, if you do here, drug B out of 100, 3 patients did not take any medications, it's 97. But 2 patients took drug B, it's 99. But remove 3 patients, it will be 96 again. So this is why 96 took drug B. So the efficacy is where you take into consideration only those who took the drug under consideration. Sounds good? Okay. Now effectiveness, you notice that there were 100. And in the analysis, I took 100. So among those 100, there are 5 who did not take any drug. And there were 3 who took drug B. But I don't care about them. Why? Because I want to see the effectiveness of the treatment as a whole. Okay? So I want to test when I introduce this drug into the market, how much saving do I do? How many less people with the disease do I have? In other words, in the real world, when I introduce this drug, I have people who do not take them. I have people who switch to other drugs. And I have people who do not comply. But I'm not interested in the individual part as much as I'm interested in the effectiveness of the whole group. Okay?
What kind of study design is suitable for rare exposures and that's suitable for rare outcome?
Okay, thank you very much for the question. I mentioned earlier when I was talking about the cohort study and case control studies about the appropriateness of rare exposures and rare outcomes. And I will go back to this slide, which highlights the advantages of a case control study. It says a case control study is good for rare diseases, and a cohort study is good for rare exposures. Let me explain to you what's the difference between them. Assume that I'm trying to do a rare outcome. Let us think of retinoblastoma as a rare outcome. Retinoblastoma is a tumor in the retina, okay? And it's a very rare outcome. So assume I want to do a cohort study, okay? Assume I want to do a cohort study to see the effect of PCUs on retinoblastoma. Do those who use the computers a lot have more chances of having retinoblastoma or not? So if I want to design a cohort study, how would I design it? I would start with the exposure. So I will say I will take 100 people, let's say, or 1,000 people, and 1,000 people who are not PC users. Okay? So I'll take people who are programmers and so on and so forth, and I will put them into the PC users. And some people who have nothing to do with computers and do not have computers at home, and I take them as non-PC users. And how long do I have to follow them up? Because it is a tumor, I have to have at least 20 years of follow-up. So after 20 years, how many do you think will have retinoblastoma among these 1,000? The answer would be almost none. Why? Because this is a rare outcome. Maybe 1 in every 100,000 people will have retinoblastoma. So eventually, you waited all this time to have maybe 1 patient or even 0 patient. Right? The same thing here. Among 1,000 non-PC users, you might have none. So is it a good study? Absolutely not. So a cohort study is not good for a rare outcome. How would I do this? I would do it in a retrospective manner from a case control. How would I do that? I will identify 100 people with retinoblastoma, and I will take, let's say, 200 people controls. How do I identify these? I'll go to an eye specialist hospital, for example, which has information about people with retinoblastoma, and I give them questionnaires about their PCUs in the past, and eventually I will do the analysis. Sounds good? So this is a rare outcome. The same thing applies to a rare exposure. A rare exposure, assume that a rare exposure, for instance, is radiation. A lot of people are exposed to radiation, most probably not. If I'm interested in doing radiation and, let's say, birth defects among babies, radiation of the mother, exposure to radiation in the mother, and the incidence of birth defects. If I want to do a case control study, what would I do? I would take, let's say, 100 birth defects and 100, let's say, or 200 non-birth defects, and I go to their history and see who was exposed to radiation. But since it is a rare exposure, not a lot of people are exposed. How many do you think out of those 100 will have the exposure? Almost none. And how many among those? Almost none. So I did the study with no outcome or no beneficial result. So what I do is I do a cohort study where I'll take 100 patients or people who have radiation positive, 100 people who have radiation negative. I'll follow them up to see who has birth defect. Okay? So, as a summary, a cohort study is good for rare exposure. A case control study is good for rare outcomes. Okay?